Good morning, everyone. Thank you for coming to our CIVIC today, Thyroid Awareness Month. Learn more about your metabolic gatekeeper. Our presenter today is John Falcone. Dr. John Falcone completed his residency training in internal medicine and clinical fellowship in endocrinology at New York Presbyterian Weill Cornell and Memorial Sloan Kettering Cancer Center. He is board certified in internal medicine as well as endocrinology, diabetes, and metabolism. John is currently pursuing clinical research on the use of whole genome sequencing for precision medicine in patients with diabetes and other metabolic diseases. In addition to his research, John cares for patients with a variety of endocrine disorders, including diabetes, obesity, and conditions affecting the thyroid, adrenal, pituitary bones, and both male and female hormones. So today's session, we will be recording, and if you have further questions, you can feel free to email us as well. I'll put our email in the chat, and I'll also include it on the description on our YouTube channel. The next voice you'll hear is Dr. Falcone. Thank you for coming.
Thank you so much, Agnes, and Happy New Year, everyone. I am really happy to be here with you all to talk about a very important topic, the thyroid. And I think today's goal will be to introduce what I'm sure we have all heard of from family, friends, neighbors. Thyroid conditions are very common. And so I think the goal of today's talk will be to introduce the gland and to make everyone familiar, hopefully familiar with some of its function and some of the conditions where the thyroid function can go wrong. So the next time we hear someone else talking about the thyroid, we'll be familiar with the condition. So today's objectives, so I want to introduce what actually is the thyroid gland, what are the normal function of the gland, how is it regulated, and then we'll get into some disorders, so when normal function goes wrong. So first off, what is the thyroid gland? Well, we have to take a step back. What is the endocrine system? And the endocrine system, so I'm an endocrinologist, or a hormone doctor, and the endocrine system is a complex network of glands and organs that secrete hormones into the bloodstream. They go through general circulation, and they get to a different site in the body where they either excite or they inhibit the activity of another organ or tissue. And a hormone is a chemical messenger that gets secreted by one part of the body or gland and exerts its function or its effect on a different part of the body. So the thyroid gland is a butterfly-shaped gland, sits just below the Adam's apple along the front of the windpipe. And in a normal-sized gland, you may have some difficulty feeling it, but if you feel where your Adam's apple is and then go just south of there, that spongy material is where your thyroid lives. And it is composed of two side lobes that's connected by a bridge in the middle, or what we call the isthmus. And a little bit beyond the scope of this talk, but just so that we're familiar with it, because conditions of the parathyroid glands is very common. So we may have heard of it, and it's oftentimes confused with the thyroid. But I want to just refer to, there's 4 sesame seed-sized glands that are called the parathyroid glands, and they're positioned just behind the thyroid and actually live within some of the thyroid tissue. The role of the parathyroid glands is very different than the thyroid. Their hormone actually controls calcium metabolism and calcium regulation, but just so that we're familiar. So normal function of the thyroid gland. So the thyroid secretes several hormones that collectively are called thyroid hormones. And the main ones that you'll hear are thyroxine, or what's also called T4 for short, and then triiodothyronine, or T3 for short. And you see here in the diagram on the right, there's the thyroid gland secreting T4 and T3. And it also secretes another hormone called calcitonin, which is disorders of calcitonin are not very common and is a little bit beyond the scope of what I want to focus on today. So thyroid hormones target pretty much every cell in the body, and they influence a wide range of normal physiologic function. And these include metabolism, energy utilization, how quickly our cells consume oxygen. Also is very important for babies, for fetuses, for children in normal growth and development, and that skeletal, muscular development of the nervous system. I took this from one of the other endocrinologists, but I oftentimes will tell my patients, young women who have disorders of the thyroid, I said, when you find out you're pregnant, the first thing you do is call your partner. The second call you want to make is to me. And that's because thyroid hormone and ensuring that we have normal thyroid hormone levels in the body during pregnancy is very critical for normal development of the baby. Thyroid hormone is also involved in regulation of body temperature, as well as it has direct effects on the heart and its role in increasing heart rate and force of contraction, as well as how our body responds to stimulatory hormones like adrenaline. So the thyroid is a unique organ because it actually takes up iodine, which is an essential element needed for normal thyroid hormone production. And our body can't produce iodide, and we must get it all from our food. We'll get a little bit about why this matters, why this is important, but it does make the thyroid a very unique organ. In the United States, we don't see deficiency of iodide very often because salt has been iodized for many years now, where iodine is added to the salt to ensure that we do obtain the necessary levels of iodine in our diet. Also, what makes the thyroid unique is that unlike other endocrine organs, such as the pancreas, where the pancreas will produce insulin and it goes directly into the blood and out into the body, the thyroid actually produces that hormone and stores a good amount of it within the gland, and then it secretes it as needed. And so we'll get into why that's important as well when we get into some disorders of the thyroid. But it's important to remember that the thyroid is unique in that it stores its hormone within the gland. So regulation. One of the things that makes the endocrine system unique is that there's these pathways. You'll see that image on the right. Pathways that control the regulation of different organs. And it may seem complicated at first, but once you learn the different pathways and the levels of regulation, the endocrine system is actually a very elegant, neatly designed system that really makes sense. And so I think it's important that we have a basic understanding of this regulation pathway. So you'll see here on the upper picture on the right, the pituitary gland, which is that pea-sized gland that lives up in our brain. I often describe it as the mother of all endocrine organs because it secretes hormones that go out into the body and stimulate or tell to work all of the other endocrine organs and when to work. In the case of the thyroid, it secretes a hormone called thyroid stimulating hormone, or TSH. And the job of that is to go down through the blood to the thyroid and tell the thyroid gland to work to produce hormone. And it is the most physiologic marker of thyroid hormone action in the body. Above the thyroid, so you see in the picture, in the diagram, is above TSH in the regulatory pathway is a hormone called TRH, or thyrotropin releasing hormone. This is produced by the hypothalamus in the brain and is secreted and stimulates the pituitary to produce TSH. Not as important clinically, but it is important in understanding the regulatory pathway. And why this is important, TRH and TSH, is because they act as a quote unquote thermostat. And the role of the pituitary to continuously sense the amount of thyroid hormone in the blood. When there's not enough hormone in the blood, when it increases its production of TSH to tell the thyroid to work harder and produce more hormone to get the levels up. For whatever reason, if the thyroid hormones are a little bit too high, the pituitary gland senses that and it decreases the amount of TSH it's producing in order to let the thyroid gland to stop stimulating the thyroid gland and let the thyroid hormones come down a bit. So it's a very elegant system that functions to ensure that we always have normal thyroid hormone in the blood. And we can take advantage of TSH and its role in regulating thyroid hormone in order to get a gauge of what is the status of thyroid hormone in the body. And we'll get into that in a little bit. So some disorders of the thyroid gland. So the thyroid disorders can range from something as benign and harmless as goiter, which just means an enlarged thyroid gland that doesn't require any treatment, all the way to life-threatening thyroid cancer. However, the most common thyroid disorders we see are disturbances to the normal thyroid hormone production. So I want to start off by talking about hyperthyroidism, which means too much thyroid hormone. So hyper, that prefix means too much. And I want to start off by illustrating this topic with a case. So Mr. A is a 20-year-old male. He has no medical problems, but after having several weeks of feeling anxious, racing heart rate, and increased sweat, he went to the emergency room. One of the initial blood work that the team did in the emergency room showed he had a low TSH and an increased T4 and T3. So this is classic lab work demonstrating hyperthyroidism. So we have high levels of T4 and T3, the actual thyroid hormones secreted by the thyroid. The pituitary senses that there's a lot of thyroid hormone around in the body, and so it decreases how much TSH it's producing. It says, I don't need to stimulate the thyroid anymore. There's already enough hormone going around. And so this is, I think, I always try and explain to my patients this pattern of blood work because it can be a little bit confusing that you have a low TSH but high thyroid hormones, and that's consistent with, very classically consistent with hyperthyroidism. So some common causes of hyperthyroidism. The most common is a condition called Graves' disease, and we'll talk a little bit about this next, but to introduce it, it's an autoimmune disease. And an autoimmune disorder occurs when your immune system produces antibodies that attack your own tissues. And in this case, the immune system produces antibodies that overstimulate the thyroid to produce hormone. Next, you can have a toxic adenoma, which in other words are nodules or growths on the thyroid that begin to secrete thyroid hormones. I always use the reference, it's kind of like the bad kid in class, not listening to the teacher, just doing whatever he or she wants to do. So not under the regulation of TSH, but it's just a growth that starts producing hormone as it likes. Many nodules are what we refer to as cold and do not secrete hormone. And we'll talk a little bit about that later. But nodules that we call hot are growths on the thyroid that do secrete thyroid hormone. You can have a condition called subacute thyroiditis, which means inflammation or damage to the thyroid that causes the gland to leak excess hormone. And so we talked about how the thyroid actually stores a lot of its hormone. And so whenever you have damage to the thyroid, you can have it passively leak the excess hormone, the stored hormone, into the blood. Many times we see this occur as a result of a viral infection, and patients can actually report experiencing cold symptoms just prior to the onset of hyperthyroid symptoms. Next, you can have medications or supplements, and this can occur from overtreatment with thyroid hormone replacement for hypothyroidism or low thyroid hormone. As well as certain supplements can actually contain thyroid hormone. Sometimes you can have supplements that are marketed for weight loss, and they actually contain thyroid hormone. And then certain medications that contain iodine can also cause a state of too much thyroid hormone. So you see here on the right is a nice cartoon depicting a diagnostic test we use in endocrinology called a thyroid uptake and scan. And this type of scan is used particularly in the diagnosis, is used particularly in the diagnosis of hyperthyroidism to help tease out what is the exact etiology of why someone has too much thyroid hormone. In this test, the patient swallows a type of radioactive iodine in the form of a capsule. And then pictures are taken to assess how much of that radioactive iodine is being taken up in the thyroid. So getting back to that, normal function of the thyroid is to take up iodine from the blood and use it to make hormone. And we take advantage of this normal physiologic process in order to help us differentiate different types of hyperthyroidism. So you see on the second row on the left, you see a hot nodule. So that's what we mentioned, a nodule, a growth in the thyroid that's acting at its will to produce thyroid hormone. And that's taking up a lot of iodine to make thyroid hormone, and it's going to light up nice and bright on the thyroid uptake and scan. To the right of that, you have what's called a toxic multinodular goiter. And what that is a fancy name for saying is you have multiple nodules growing in the thyroid, and it causes a goiter, so an enlargement of the thyroid. And the word toxic referring to the fact that these nodules are producing thyroid hormone. And as you can see that they are lighting up on the uptaken scan. On the bottom row here on the left, you have a typical image of how Graves' disease would appear. So Graves' disease, as I mentioned, there's antibodies that are stimulating the thyroid to produce hormone. So diffusely throughout the gland is uptaking higher levels of iodine and producing hormone. And so the whole thyroid lights up. And then in thyroiditis, where, as I mentioned, it's a release of stored thyroid hormone. So there's not much thyroid hormone being made, but rather the hyperthyroidism is resulting from a release of stored thyroid hormone. And so in those cases, the gland actually looks pretty pale. And just another way to illustrate thyroiditis, I explain, picture you have a full water bottle and you take a pen or a knife and you poke a bunch of holes in the thyroid in the water bottle. That water is going to start leaking out of the bottle through the holes. And that's how I like to use an analogy I use to describe thyroiditis. So to speak a little bit more about Graves' disease, as it's very common and accounts for about 60 to 80% of cases of hyperthyroidism. It has about an 8-to-1 predominance in females and typically occurs in younger ages, people aged 20 to 40. That's probably the mean age, but we do see it in all different ages. And as I've already mentioned, it's an autoimmune disorder where antibodies target the TSH receptor, and this leads to the hyperstimulation and hyperfunction of the gland. The most common one you'll hear your provider talk about, the most common antibody, is what's called thyroid stimulating immunoglobulin, or TSI. So if someone comes in with hyperthyroid blood work, that is going to be one of the first follow-up tests we'll check, will be to see if they have these antibodies that are stimulating the thyroid. And you see that here depicted in the diagram on the right. You see the antibodies out in the blood that are binding to the TSH receptors on the surface of the thyroid cells, which then leads to stimulation of the thyroid gland. And what you see here in the bottom is a picture of what's called thyroid eye disease. And this is an autoimmune inflammatory disorder of the orbit and the periorbital tissues. So these same antibodies that are stimulating the thyroid gland can also stimulate the fibroblasts, or the collagen producing cells that live behind the eye and in the orbit of the eye. And these stimulate the eye muscles and stimulate them to thicken and to grow, as well as they stimulate the fibroblasts that can then differentiate into fat cells. And the fat cells and the muscles expand, they become inflamed. This leads to compression of veins that are present behind the eye, resulting in the inability to drain fluid from the eye, and this causes edema or swelling. Altogether, all this swelling and enlargement that's going on behind the eye pushes the eye orbit forward, and it results in that presentation of what we call eye bulging or exophthalmos. Oftentimes there is a medication to help treat this, but many times also these patients will require surgery to help decompress or take down some of that enlarged muscles and fat tissue. So getting back to more general hyperthyroidism, some symptoms that having too much thyroid hormone around will present with will be a tremor, or you notice that when someone outstretches their hand, you'll notice a shake, similarly to like if someone had too much coffee. They can have nervousness, a fast heart rate. They can feel tired. They can have diarrhea. They can sometimes report an unintentional weight loss, difficulty concentrating. And then I'll ask, do you feel hot when everyone else in the room you're with feels comfortable? And that's significant for an intolerance to heat. Think about it like everything in the body is sped up. So treatment for hyperthyroidism, what do we do? So the type of treatment really depends on what we determine to be the cause of the hyperthyroidism. But in general, you'd want to adjust any medications or supplements that may be causing the high thyroid hormone levels. In cases of a thyroid nodule or Graves' disease, sometimes we give a small dose of radioactive iodine. So this is a slightly different form of iodine than I talked about that we use for the uptake and scan. It's a slightly different type of radioactive iodine that actually gets taken up by those thyroid tissues and can actually kill off or ablate some of those overactive thyroid cells, and can often lead to the normalization of thyroid hormone levels. In some cases, we refer to surgery to either take out a part or the entire thyroid gland. And then there's medications. We call anti-thyroid medications, what are named methimazole and propylthiouracil, or PTU for short, that work to decrease the amount of hormone the thyroid is producing. We'll also commonly use beta blockers or medications that work at the heart to decrease the effect of thyroid hormone on the heart. And because we talked about how the thyroid can lead to thyroid hormone can lead to fast heart rate. And so we give beta blockers to help decrease the effect of thyroid hormone on the heart. Most commonly are propranolol, metoprolol. So back to our patient, Mr. A. After his initial blood work was consistent with hyperthyroidism, additional blood testing showed that he had a positive thyroid stimulating immunoglobulin, or TSI, that was consistent with Graves' disease. He was treated with methimazole for 1 year. And a side note related to that is many patients, when they're diagnosed with Graves' disease, if they're treated with antithyroid medications, methimazole or PTU, for 12 to 18 months, can actually go into remission. And what we do is we slowly taper down the dose of these medications while monitoring very closely their thyroid hormone levels to see if they're in what we call remission, or normal thyroid hormone levels, without any further treatment. However, a good number of patients will not go into remission, will require further what we call definitive therapy. And so Mr. A received a small amount of radioactive iodine therapy that normalized his thyroid hormone levels, resolved his symptoms, and he did not need any further medication. So moving along to hypothyroidism, or too little thyroid hormone, we have Miss F, who is a 50-year-old woman. She has a history of being overweight, high cholesterol, and she went to her primary care doctor stating she felt more tired. She was experiencing difficulty losing weight, had some constipation, and she noticed her memory wasn't as sharp as it used to be. She initially attributed these symptoms to menopause. However, her neighbor pointed out to her that her hair was thinning, and the neighbor recommended that she go to her doctor to have a checkup. So the primary care provider performed a full physical, as well as did some blood work for Miss F. And her blood work results came back with an elevated TSH and a low thyroxine, or T4 level. And this is a very classic presentation for hypothyroidism. So you have low thyroxine, so low thyroid hormone. The pituitary gland senses that there's not enough thyroid hormone around, and so it increases production of thyroid stimulating hormone, TSH, in an attempt to try and get the thyroid to work more. So some common causes of hypothyroidism can include Hashimoto's thyroiditis, which is an autoimmune condition. And this is the most common type of thyroid disorder in the United States. It can also result from iodine deficiency, which is the most common cause of hypothyroidism worldwide. Hypothyroidism also results from thyroid gland surgical removal, different medications. And I just want to back up. I want to explain I'm going to talk a little bit more about Hashimoto's, but Hashimoto's is an autoimmune disorder in which, similarly to Graves' disease, you have production of antibodies against the thyroid. However, these lead the immune system to actually attack the gland and impair its ability to produce hormone. Thyroid gland removal, surgical removal of the thyroid gland, results in a lifelong need to take thyroid hormone replacement. So for whatever reason, whether it's for hyperthyroidism or thyroid cancer, someone has a surgical removal of the gland, they need to take a pill that replaces the hormone that the thyroid would make. Medication. So over-treatment with those medications I mentioned for hyperthyroidism that impaired the thyroid's ability to make hormone. So if you over-treat with those medications, or a medication called lithium, which is used for certain mood disorders, can result in low thyroid hormone levels. Radiation therapy. So radiation used to treat cancers of the head and neck can actually impair the thyroid gland and may lead to hypothyroidism. Pregnancy. So due to the normal changes we see that occur in the body during pregnancy, as well as we know some women produce these the antibodies seen in Hashimoto's to their own thyroid gland, either during or after pregnancy, can result in hypothyroidism. If left untreated, as I referred to before, that thyroid hormone is very important for normal growth and development of a baby. And so if left untreated, hypothyroidism can result in miscarriage, premature delivery, and preeclampsia, which is which is a condition that causes a significant rise in a woman's blood pressure during the last 3 months of pregnancy, and can seriously affect the developing fetus. And then also pituitary disorders. So we talked about how the pituitary produces TSH that stimulates the thyroid. So if there's something wrong or something impairing the pituitary's ability to produce TSH, that can result in low thyroid hormone levels. And we call this secondary hypothyroid. So disorders with the thyroid itself being able to produce hormone, we call that primary hypothyroidism. But when it comes from the pituitary not able to produce TSH, we call that secondary hypothyroidism. And this can result from either benign growth or adenoma in the pituitary gland, or radiation to the brain can impair the pituitary's function and result in decreased TSH levels. So I want to talk a little bit further about Hashimoto's. So this also has a predominance in women, about 6 times greater than in men. Mean age of diagnosis is a little bit older than in Graves' disease, so it's around age 60. And the prevalence, we do see this that become more frequent as we age. We also see it tend to run in families. So oftentimes we'll ask, especially any of the female members of the family, if they had any diagnoses of thyroid disorders or Hashimoto's. As I've already referred to, it's an autoimmune process with the most common antibody occurring in about 90% of cases is this antibody called anti-thyroperoxidase, or anti-TPO for short. And we'll often check that in someone coming in with low thyroid hormone levels. Interestingly, this condition may present with an initial period of hyperthyroidism because it's actually a thyroiditis, or that damage that we mentioned that occurs to the thyroid gland resulting in the release of the stored thyroid hormone. But then over time, you have a slow progression to hypothyroidism over years. And this comes about from the antibodies that target the thyroid lead the immune system to actually attack the thyroid gland, leading to scarring and an inability of the thyroid to produce its hormone. And it's very commonly associated with other autoimmune conditions. We know autoimmune diseases commonly occur together. And so we see this commonly in type 1 diabetes, but also patients who have celiac disease, pernicious anemia, and vitiligo. So some symptoms of having too little thyroid hormone can include fatigue, constipation, dry or brittle hair and nails, dry skin, brittle hair and nails, difficulty losing weight. People can feel like a weakness in their muscles as well as muscle ache. They can have high cholesterol, difficulty remembering things, difficulty concentrating. Women can report heavier periods or irregular menstrual periods, and feeling a low mood or depression. Also, just one more time to talk about the role of thyroid hormone in pregnancy. Hypothyroidism, as I mentioned, poses a special risk to newborns and infants. There's 2 specific syndromes: congenital iodine deficiency syndrome, or what used to be called cretinism. This is a condition that's present at birth and marked by impaired physical and mental development. And around the world, the most common cause is due to iodine deficiency. Also can present with dwarfism. And then outside of the specific syndromes, having not enough thyroid hormone during gestation can result in premature birth, pregnancy loss, low birth weight, and lower IQ. So how do we treat hypothyroidism? So you want to treat the underlying cause, so adjust any medications that may be resulting in low thyroid hormone levels. But essentially the mainstay of treatment is going to be replacing thyroid hormone thyroxine, or T4, with a medication called levothyroxine, or Synthroid, is the brand name. After initiation of levothyroxine, your provider would want to check lab tests about 6 weeks to ensure that it is the right dose of thyroid hormone, and then to adjust the dose as needed. And then I always like to emphasize with my patients the proper way to take levothyroxine, because it is a hormone. It is very picky in the way in order to ensure proper absorption of the medication. So I always recommend patients take the medication by itself, not with any other medications. Take it with water only on an empty stomach, And then you want to wait about 30 to 60 minutes before eating or drinking anything other than water. And this is really to ensure that the body is able to properly and fully absorb the medication. We know different foods, different medications, different vitamins or supplements can really impair and result in impaired absorption of levothyroxine. So returning to Miss F, her follow-up blood work showed positive TPO antibodies consistent with Hashimoto's disease. She was started on levothyroxine, and after several weeks, she reported a gradual improvement in many of her symptoms. So the last topic I want to talk about this morning is on thyroid nodules and thyroid cancer. And so to illustrate, Miss P is a 60-year-old woman. She went to see her primary care provider for a routine annual physical. And on physical examination of Miss P's neck, the primary care noted a new growth on her thyroid. And if you see here in the bottom right corner, I put this picture to illustrate what a normal thyroid exam would look like. Some providers do perform the exam from the front approach. I typically, I learned how to do it from behind the patient, where you put both your hands over the patient's windpipe with applying a little bit of pressure. And in that you can assess the texture of the thyroid, whether it feels firm or soft. You can assess the size of the thyroid. And then I ask the patient to swallow. Often we'll give them a cup of water and ask them to swallow. And as they swallow, it actually brings the thyroid up and down and runs it below my fingertips, where I can assess for the presence of any nodules or growths. So after the primary care provider noted the growth on Miss P's neck, she checked some thyroid hormone levels in the blood, which were normal, and then recommended Miss P have a thyroid ultrasound done in order to get a better look at the growth that she felt. Here we go. Okay, so to first clarify, a thyroid nodule is defined as an abnormal growth of the thyroid cells that form a lump within the thyroid glands. Many times these growths are picked up on a routine physical exam, as in the case of our patient. But they also may be picked up incidentally on imaging of the head, neck, chest that's done for some other reason, and it may be noted that the patient has a thyroid nodule. And if you look here, this is an ultrasound of the thyroid. You see here the windpipe or trachea present in the middle. You see the presence of a thyroid nodule highlighted in red in the right lobe of the thyroid. And then you see up top above the trachea is the isthmus or the thyroid bridge. And then you see the part of the left thyroid lobe. And then you also, they also point out the carotid artery, which is the large artery that goes up our neck into our brain. And that's what you feel when someone checks a pulse in the neck. You're feeling for the carotid artery. So that's what a thyroid ultrasound would look like and how a nodule appears on an ultrasound. So the differential diagnosis, or when someone is diagnosed with a thyroid nodule, what could that be? Well, it could be a hyperplastic or a colloid nodule, which is very common. It could be what's called a follicular adenoma, which again is a growth of thyroid tissue. It could be a fluid-filled cyst present in the thyroid tissue. And it could be thyroid cancer. While most thyroid nodules are benign or non-cancerous, about approximately 5% of nodules are cancerous. And cancer of the thyroid gland is quite rare. They represent about approximately 1% of new cancer diagnoses each year in the US. We are diagnosing more and more thyroid cancer, which we attribute to increased imaging modalities that are allowing us to pick up very small thyroid cancers that normally or previously we would not have been able to pick up or identify. Most thyroid nodules are asymptomatic, although there's two exceptions to that statement. One would be if the thyroid is secreting hormone, as we mentioned in our hyperthyroidism section, a hot nodule will present with symptoms of hyperthyroidism, or if the nodule becomes large enough. It may present with a feeling of neck fullness, or it may present with a feeling of pressure either on the windpipe or the esophagus, resulting in a feeling of shortness of breath, difficulty swallowing. And if you see here in the bottom image, some patients will present with an appearance of a swelling in the base of the neck. The initial evaluation after identifying a thyroid nodule is to check thyroid hormone levels, and that's to see if the nodule is secreting hormone. So that would be our TSH and our T4, and then to obtain a thyroid ultrasound, and that's to better characterize the nodule. Certain characteristics of the nodule make us more or less suspicious for thyroid cancer. If the ultrasound does show certain characteristics that raise our suspicion for thyroid cancer, the next step is to perform what's called the fine needle aspiration biopsy, or FNA, you'll hear. And this allows us to take some cells from the nodule to be examined under the microscope to assess if it poses any characteristics that are suggestive of cancer. And so you see here in the right, two images demonstrating how an FNA is done. We actually do these right in our office, or a patient can be referred to interventional radiology to have this performed. And you see here in one hand, the operator is holding an ultrasound that allows the operator to visualize the nodule, and then uses a small needle to inject into the nodule to aspirate some tissue from the growth. And this is just done. We use a cold spray on the neck to numb up the skin. And it can be done really very quickly without much pain or bleeding or risk of infection. Now, if a nodule is determined to be cancerous, the person is typically referred to a surgeon for surgical removal. And further management of the thyroid cancer really depends on the type of the thyroid cancer. There's several different types of thyroid cancer, and the extent of spread. The 5-year relative survival rate, again, really depends on the type of thyroid cancer and the degree of spread. But for the most common type of thyroid cancer, the 5-year relative survival rate is very good, at 76% if there's distant spread present, to near 100% if it's diagnosed at a local or a low stage. So getting back to our patient, Ms. P had an ultrasound done, and based on the size and characteristics of the nodule, her provider recommended that she undergo a fine needle aspiration, and then the pathology from that biopsy showed a benign adenoma, and no further action was needed for Ms. P. So I'd like to summarize. The thyroid gland plays an important role in the human body. And as you've seen in conditions of hyperthyroidism, hypothyroidism, the symptoms that it can present with can be very vague as well as very broad. So if someone is Google's symptoms that they may be experiencing to see what could be the cause, many times, more often than not, some type of thyroid dysfunction will be present on the differential and what someone will find as a possible cause. Luckily, thyroid disorders can be easily identified via blood tests by checking a TSH, a T4, and T3. And just to review, the common presentations, a high TSH with a low T4 is consistent with hypothyroidism or low thyroid hormone, whereas a low TSH and a high T4 is consistent with hyperthyroidism or high thyroid levels. And this is because T4 and T3, their secretion is under the control of TSH from the pituitary gland, which acts as a sensor of thyroid hormone levels in the blood. We also will check thyroid antibodies, thyroid ultrasound, and thyroid uptake and scan to help us clarify a diagnosis of what specific type of thyroid disorder may be present, as well as that guides us in determining a treatment plan. Conditions of abnormal thyroid hormone secretion can be treated with medications, radioactive iodine therapy, or thyroid surgery. And then lastly, we talked about thyroid nodules being very common, with the majority being benign. We covered a lot, and some of these topics could have been a whole talk in and of themselves. But I think we have some time for questions if anyone has questions on our topics.
Yes, thank you, John, so much. That was a lot of information. I'm going to actually administer a poll It's a quick anonymous poll, just a survey on who's here today. And then while that's happening, you can also ask questions. I also received questions in the chat. Okay, and I will also put the email in the chat for those that would like to ask questions if it comes to them later on. I know usually I'm thinking throughout the day, I'm like, oh, I should have asked that question.
Well, I have a question. This is
Yes.
Diane Mack. I'm curious. One of the things that was very interesting to me and thinking about the people that I know that have hypothyroidism is also the way the pituitary gland was introduced as part of the endocrinology system. And I don't get that heard talked about as much. Going to the doctor or ask those questions. And some of the items that you highlighted on the slides made me think about these folks and what's happening with their pituitary. So that's one. And then the second part of that is, what other ways might people experience endocrinological problems, but not rise to the level that it's a problem yet?
Very good questions. Yeah, I think the pituitary gland, as I mentioned, the mother of all the endocrine, secretes a lot of different hormones that control different endocrine organs, tell them to work. And we take advantage of the pituitary gland by checking the different hormones, and we use that as kind of our sensor. In endocrine, we always look at everything in relation to one another. So a low TSH, let's say with a high T4, a classic picture for hyperthyroidism. There's high thyroid hormone levels, the pituitary senses this and decreases. Versus a low TSH with a low T4. This is a completely horse of a different color. That would be what I refer to as secondary hypothyroidism. So the pituitary not functioning enough for whatever reason, not producing its hormone. And so the thyroid not getting enough stimulation. And that's why we actually have the low T4. So in endocrine, we always think about our hormones in terms of relation to one another, and with the pituitary being one of the most important. And important to keep in mind as well as the history for the patient. Does the patient have any history of radiation or any type of brain mass that may have impaired the pituitary function? And in terms of you were asking about some abnormalities within the endocrine system that before they actually present with full-on hypothyroidism, let's say. So that's a good question. That's actually has a name. It's called subclinical hypothyroidism. So an example of that would be someone who has a low TSH. So I see a low TSH, the first thing I think of, has a high TSH, the first thing I think of is hypothyroidism. But let's say we check their T4 and it's normal. So that is what we call subclinical. So they still have actual normal thyroid hormone levels, but the TSH is high, meaning that probably at some time, the pituitary is sensing low thyroid hormone levels, and it's compensating by increasing TSH and increasing the hormone production in the thyroid gland. And so while the person may not have any symptoms of hypothyroidism at that time, it's something we want to monitor for, because it may progress to overt hypothyroidism, as well as given the degree of how high the TSH is, whether we decide to treat at that time or not. That's oftentimes a discussion, and we have further considerations with regard to the specific patient. But that's a very good example of what we call subclinical hypothyroidism.
I have a question. Hello?
Yes, hi.
Hi. Why are women more susceptible to getting hypothyroidism and Hashimoto disease than men? Is it because women tend to get it at a later age because of menopause and the hormone levels are a lot lower, or is it something else?
I think autoimmune conditions as a whole are more common in women. And so in both Graves' disease and Hashimoto's, both those autoimmune conditions have a greater prevalence in women than in men. I think that's probably the most likely explanation, is that, you know, we just see autoimmune conditions more common in women in general. And I don't think it has any relation to do with, let's say, menopause. Why Hashimoto's tends to have a little bit of a later age of onset, I think because it takes time for those antibodies and the immune system to attack the thyroid gland, lead to scarring of the gland and impaired function. And that studies that have looked at, you know, it actually happens over, it's a subtle decline. It's not, let's say, like an abrupt decline in the thyroid's ability to produce hormone. So it's probably a process that's been going on for a majority of a woman's life or a person's life. And then by the time the mean age is 60, by the time they get into those later years in life, that the thyroid hormone production levels start to fall off to the point where it gets diagnosed.
Okay. All right, thank you.
Hi, I actually had a question in the chat from Larry, asking if you can discuss the impact of alcoholism on the thyroid.
That's a good question. You know, I'm thinking if I've ever come across anything related to alcohol intake and thyroid. I don't know if I know of any direct associations between alcoholism and thyroid. I would have to look that up to see if there have been studies done. Certainly, I would think any type of thyroid dysfunction, you would not want to, you know, have high alcohol intake, whether you're hypothyroid or hyperthyroid. That would not be a good combination. But I would have to take a further look in the literature to see if it's ever been looked at any direct effects of alcohol on the thyroid.
When you do the naive scan through Google, you get some suggestions that alcoholism protects you against Graves' disease. Then you get other ones saying depression, diarrhea, depression. Scrambled eggs. I mean, you don't get a clean signal. And your consternation with the question says there's no clean signal to be had. Thank you.
Yeah.
There was another question in the chat, and when taking medication, well, once your thyroid is removed, what's something you should know about your medication? And then I have a couple more questions about food.
Was that in terms, did you say, Agnes, when the thyroid is removed?
Yes, when the thyroid is removed.
Mm-hmm. Yeah, so as I mentioned in the talk, when the thyroid is removed, either for one reason or another, Graves' disease, thyroid cancer, your body then is dependent, or you're dependent on taking levothyroxine or thyroid hormone replacement in the pill form. And that's because once the thyroid is removed, there's no other way to produce thyroid hormone in the body. And thyroid hormone is necessary for life. People can get very, very sick if they don't have any thyroid hormone around. And so, you know, it's something that, you know, I tell patients that you just, you know, it's something that's going to be lifelong. And I always recommend my patients get a pill box, and they use that pill box to help them always remember every day to take their thyroid hormone pill, their levothyroxine, because it is very important. And yeah, that's it's something that's lifelong once the thyroid is removed. And that you know, using setting an alarm on your phone, putting sticky notes in the bathroom, anything that you can use to help you remember to take your thyroid hormone pill is going to be very important.
Yeah. Another question regarding food. Is there some good or bad food you should avoid or consume more? Or should you be consuming more salt to prevent thyroid disorders?
Yeah, in terms of salt, so the American diet, I think, already gets plenty of salt, that you don't have to worry about, you know, am I getting enough salt with enough iodide to make sure that I'm getting sufficient levels of iodine for my thyroid. You know, what we typically eat in the United States has plenty of salt and hence plenty of iodine for normal thyroid function. So you don't have to worry about that. In terms of one interesting paper I came across was talking about in certain cultures where I think they consume a lot of seaweed dietarily. Seaweed, we know, has iodine in it, and so that is something to think about. Other than that, I don't know about any real other associations between diet and the thyroid.
Okay. And Larry asks, how about salt iodine hypertensives reduce salt intake? Set that in the chat.
Yeah, absolutely. People who have hypertension or high blood pressure would want to reduce their salt intake. But even, at those reduced levels, one diet is called the DASH diet, which is a low sodium diet for people with high blood pressure. And even that, though, this quantities of salt in the diet are still sufficient for the thyroid.
Okay, awesome. And is there a group of people or populations that's predisposed to thyroid?
Definitely. So the risk factors are, like we've talked about, are women, people have a history in the family of thyroid, of some type of thyroid disorder, people who have another type of autoimmune condition, anyone who has had any trauma to the neck. So I've heard of a case of someone who had a car accident and actually the seatbelt damaged the thyroid. They had an injury to the thyroid from the seatbelt. Any type of radiation to the head, neck, and that could be for cancer. I think I've heard also for people who in their teenage years had radiation for their acne. That also can impair the thyroid. I would say that's probably the most common, risk factors to look out for.
Okay, so nothing related to like ethnicity wise, right? Or
you know what, I haven't actually looked up those statistics in terms of ethnicity. I know in my practice, I see from all different ethnicities. Anecdotally, I don't notice one ethnicity having a higher rate than another.
okay, cool. Thank you. I don't see any more questions in the chat, but I also inserted the email and I will also put it in the description on the YouTube, on the recording of the YouTube that I will share with everybody on the email chain. Okay. Thank you so much.
Maritia has a question.
Oh, yes.
Hi, thank you. Thank you so much for acknowledging. My doctor told me about 5 years ago, I have nothing of what Mr. John Falcone said. I am a very healthy woman. There's nothing wrong with me. I love to eat. He told me I needed to remove my thyroids. And for some reason, I disagreed with him. I'm not a doctor. But when he told me that I needed to remove them, I never went back. I went to another doctor and they told me that I just needed to be careful what I eat and I had to do physical activity and that was it. But I still have them. But I found that strange. I think it's a misdiagnosed because I was gaining weight, losing weight, gaining weight, losing weight. And he said it had to do with a thyroid situation. But he wanted to remove them. And for some reason, my spirit did not agree. So I guess I'm saying that to say, because I don't eat a lot of salt either, but I do still have an issue with the weight gain and weight loss, no matter what diet I do.
Yeah, there's very specific situations where we would recommend someone for thyroid surgery. Certainly, we would start from the beginning. What are the actual thyroid hormone levels, the TSH and the T4? Maybe the next step would include a thyroid ultrasound. But there's a whole process that we would work through before recommending someone have a thyroid surgery for treatment of their thyroid disorder.
Thank you, because he didn't offer none of that. So I was on point. So, but I'm good now.
And just to clarify too, because parathyroid, just to clarify, I mentioned that there's the thyroid and then there's the parathyroid, those sesame seed-like glands that there's 4 of them that live behind the thyroid. Now, I didn't get into it, but they can sometimes oversecrete their hormone. And the mainstay of treatment for that is to take whichever one is misbehaving, is oversecreting their hormone, is to have that surgically removed. And I know sometimes because the names are just so close, they sound so similar, they can be easily confused. So always, when someone talks about similar to what you've stated, Maritza, I always like to just point that out. Maybe they mentioned parathyroid, which can affect calcium levels.
Okay. Thank you. Thank you so much for clarity. Thank you. I appreciate it.
Of course.
Now that you mentioned calcium levels, would someone develop osteoporosis or lead to other disorders now?
Certainly with relation to osteoporosis, so having hyperthyroidism for a long time can actually lead to weakening of the bones and osteoporosis. So when I see someone for osteoporosis, one of the initial blood works I check are their thyroid hormone levels to make sure that they don't have hyperthyroidism that's just never been diagnosed that has led to the weakening of their bones. And that's relation to the thyroid. And then with relation to the parathyroids, certainly, yes, elevated parathyroid hormone level over time leads to weakening of the bones or osteoporosis.
Oh, cool. Yeah. I didn't know that. Okay, so it looks like we ended the session right on time. If there's any further questions, please feel free to write in the chat or email us as well.
All right.
Yeah.
Thanks a lot, John, for presenting today. And a big thanks to
My
everybody else
pleasure.
for joining us.
Yes. Okay. Thank you, everyone.
Thank you so
Bye,
much.
everyone. Have a great day.
Enjoy the rest of your day. Bye-bye.
Thank you, John. Love
Happy
your
New
job.
Year.
Really nice
Happy
job.
New Year. Yes.
Yeah, thanks,
you.
John.
Thank you.
Nice to see you.